My name is Bill Shields. I'm the Vice President of International Sales with Diopsis. I'd like to thank everyone for joining us for our virtual symposium on integrating objective functional analysis in the everyday clinical environment. For those of you that are familiar with Diopsis, we have two excellent speakers today. One talk will concentrate on glaucoma applications, and the other will concentrate on retinal applications. For those of you that are not familiar with Diopsis, this will be an excellent introduction into the clinical benefits of our unique technology. With over 2,500 instruments installed worldwide, Diopsis is the world leader in objective functional testing designed specifically for use in the everyday clinical practice. Our technology is used for management of retinal disorders, glaucoma, neuro, and evaluation of retinal toxicity. Today, however, we will focus on our two main areas, retina and glaucoma. So it's my pleasure to introduce our first speaker, Dr. John Wroblewski. Dr. Wroblewski is a graduate of Georgetown University School of Medicine. He did his ophthalmology residency training at the University of Texas Southwestern Medical Center in Dallas. He then spent 15 months in London at Moorfields doing a medical retina and uveitis fellowship, and 14 months in New Orleans at Toro Infirmary doing a surgical retina fellowship. He opened Cumberland Valley Retina Consultants in Maryland and Pennsylvania in 1996 and has since been a principal investigator in 28 clinical protocols evaluating new pharmaceuticals for multiple retinal disorders. He's co-authored 26 publications investigating various disease states such as diabetic retinopathy, retinal vein occlusion, and inherited retinal disorders. Finally, he's the president and founder of Retina Care International, a for-nonprofit serving indigent diabetic patients in the Yucatan Peninsula of Mexico since 2005. So without any further ado, I'd like to introduce Dr. Wroblewski.
John, if I may, I'm sorry, Bill. If you could ask people to hold their questions and direct them to the question box so that we will try and get to as many questions after each presentation.
Thanks, Bill. Good morning, ladies and gentlemen, and welcome to the webinar this morning. This presentation is designed to discuss the utility of an office-based technology capable of helping clinicians quantitate and track retinal dysfunction in various ischemic retinal disease states such as diabetic retinopathy and retinal vein occlusion. I'd like to thank the organizers at Diopsis for the opportunity to speak with all of you this morning. My topic is entitled A Novel Biomarker of Retinal Function, Reproducibility, and its Correlation with Retinal Ischemia. And I am a speaker and a consultant for Diopsis. Similar to fluorescein angiography and optical coherence tomography, which quantitates structural changes of the retina and choroid, so does flicker electroretinography quantitate neuroretinal functional changes as well. The Diopsis full field flicker ERG testing is easy to use. It's non-invasive, and a standardized report is generated immediately on the spot. Testing is performed using a handheld mini Gans field stimulator, with the retinal signal being captured by the lower eyelid sensors. Each eye is tested individually. Recall that rods can only stimulate to a flickering stimulus of 15 Hertz or less, whereas the Diopsis flicker technology uses 32 Hertz, thus isolating the cone and bipolar cell signal. Most of us retinologists, when we're gauging retinal function, use a Snellen visual acuity or ETDRS visual acuity as pretty much our only functional test unless we're doing visual field testing. And as we know, central visual acuity only gauges function in the central 1 to 3 degrees of the macula, otherwise known as the fovea. On the other hand, flicker electroretinography, the functional test that we're evaluating and speaking about today, gauges function throughout the entire retina. It's a global retinal functional test assessing global bipolar cell and cone cell function. I'd like to review briefly the flicker ERG report. And before doing that, I need to speak about the vernacular, the terms that are used that Diopsis has implemented to help us track strength and timing of the response to the flickering stimulus. So traditional electroretinographic vernacular uses terms such as amplitude and implicit time to describe the recorded signal strength and response times to a flashing stimulus. But Diopsis has chosen to use the terms magnitude and phase. Magnitude evaluates the cone and bipolar signal strength, the phase value, the timing of the cone and bipolar response. Furthermore, in addition to just looking at the average magnitude or the average phase, it also generates a report that evaluates the variance, the magnitude variance ratio, the phase variance ratio, which assesses the consistency of the response. Right now, I'm going to be speaking about the fixed luminance flicker test. And the fixed luminance flicker test is a test that takes about 20 seconds to perform. If you do the math, 32 flashes per second times 20 seconds is 640 responses. And every one of those responses is recorded and evaluated both from a magnitude or amplitude point of view as well as an implicit time or timing speed point of view, and mapped out on this magnitude phase plot. And you can see in the middle of the report the magnitude phase plots for the right eye on the left and the left eye on the right, and that there are 640 lines, directed, as you can see on the left side of the diagram, at about 4:30 o'clock into the lower right quadrant, telling us that these responses are homogeneous and of decent speed. The standardized report of the healthy retina on the left and the unhealthy retina or diseased retina on the right is shown. And when I look at these reports, the first thing that I do, similar to looking at a chest x-ray, is I look initially at the quality. And you can see up above, there are two little green circles in the signal quality box, signal quality indicator. And if they're green, you've got a good test for each eye. And then next I look at the artifact percentage. And the patient on the left, you can see the artifact percentage is 5.6 in the right eye and 5.0 in the left eye. And anything less than 10 is reasonable. Anything less than 5 is very good. And artifacts obviously are a function of blinking or losing fixation. If you look at the magnitude phase plots on the right, you can see that the responses are quite heterogeneous and variable, as opposed to the uniform responses on the left. This indicates disease. Furthermore, if you look at the magnitude variance ratios and the phase variance ratios, which again are pitted against a normal population, how consistent are the 640 responses shown into each eye? you can see that they're quite consistent on the left or on the right, both in the right and in the left eye. The responses are variable, and you can see the magnitude variance ratios are less than 1 at 0.97 for magnitude, 0.98 right and left eye, and then the phase variance ratio in the right eye is even lower at 0.9, 105 on the left. Variance ratios above 80 or 0.80 are very reasonable. Once you get below 0.80, now you're looking at significant disease, at which point the magnitude and phase values that are listed become less reliable. Finally, at the bottom of each one of these reports, you can see the data table. And again, magnitude, phase, the variance ratios and artifacts for each eye are listed, but they color code it. The green represents a value within a normal reference range. The yellow is a borderline value in that, say, last 10% of a normal reference range. And then finally, the red values indicate values that are outside the reference range. And these are an age-matched control. So Diopsis did their homework and came up with ranges in normal populations that are age matched. I just showed you the flicker ERG report of a fixed luminance flicker test. That flicker set test, again, was 640 flashes, all at 600 lumens or 600 candelas per meter square. Diopsis has also developed a second flicker test, which is the multi-luminance flicker test, which assesses 6 different luminance levels, testing each one for 4 seconds, starting at the lowest luminance level of 32 candelas per meter squared, doubling it to 64, again to 128, doubling again to 256, all the way up to 600. And the concept is that perhaps if we have a multi-luminance, a varying luminance flicker test, that perhaps it might be possible to identify or tease out subtle retinal pathology that you would not appreciate by just using the brightest flash, the 600 candelas per meter square luminance. So once again, when evaluating the multi-luminance reports, you're dealing with the vernacular of magnitude, which describes the area under the curve, assessing the cone and bipolar combined signal strength of the 6 luminance levels, and then phase, once again, dealing with timing, and it's the phase value under the curve, assessing the cone and bipolar combined signal timing of the 6 luminance levels. So in a normal eye, when you look at the flicker report of a multi-luminance test, you see once again the magnitude and phase, plotted against the different luminance levels. The test, even though it tests for 4 seconds, it actually throws out 1 second's worth of data and holds on to 3 seconds worth of data for each of the 6 luminance levels. And when I look at this report, similar to the fixed luminance flicker report, I look at the signal quality up above, the little green circle telling me that we're in business. And I also look at the artifacts, which you can see below the 2 plots. And you can see a little artifact on the right says 4% and the left says 1%. So you've got a decent test for each eye. And then I go to the mag phase plot, the circle in the middle. And what I'm looking at is the right eye is the blue line. The left eye is, responses are depicted by the yellow line. And the longer the line, the better the magnitude, the better the area under the curve for the combined magnitude testing values. And if the lines curve down to the right, similar to the similar to the fixed luminance tests, whereas you saw once again here on the left, in a normal eye, those lines are directed down to the right lower quadrant. The same with the multi-luminance. If the lines make their way down to the right lower quadrant, that tells you that the timing or the phase of each of the responses is good. And compare this with a diseased eye state, where you can see that there are heterogeneous responses, meaning that the area under the curve for each of the eyes is suboptimal. You can see that the blue line, although it does extend into the right lower quadrant, is shorter, telling you the magnitude of the multiluminance test for the right eye in combination is reduced. And then for the left eye, not only does it not get to the right lower quadrant, but the line is relatively short. And you can see that this is reflected in the table below. You can see that the magnitude for the right eye is borderline, as depicted by the yellow value, that the timing of the average of those responses was pretty good for the right eye. But the left eye, on the other hand, you can see that the magnitude area under the curve is significantly abnormal and outside a reference range altogether, and that the timing to a certain degree is marginal or reduced. So again, the multiluminance flicker test concept revolves around trying to tease out disease that you wouldn't normally see using the fixed luminance flicker. So the research goal, the holy grail for this technology is, at least from a retina viewpoint and an ischemic retinal disease viewpoint, is to see whether these functional tests can be biomarkers to assist ophthalmologists in the management of, ischemic retinal vascular disease. And we all know that, dating back to 2004 and the approval of pegaptinib by the FDA in America for exudative macular degenerative disease, and then quickly thereafter for diabetic retinal disease with center involving edema, as well as retinal vein occlusion with center involving edema, anti-VEGF therapy has become the mainstay for us clinicians in the treatment of these disorders. And so the logical thought is, can we use this functional test as a biomarker to help us track these diseases and manage them appropriately? But before you can do that, you have to have a strategy, and that strategy I've outlined here as being a 5-point strategy. First, you need to establish reference data in a normal population, which Diopsis has done and been doing, dating back to 2014-15. Then you need to see whether the test results are reproducible in a normal, healthy population. Once you've ascertained that it is, then you ask the question, well, is it reproducible in an individual with some form of retinal pathology? And in today's discussion, we're going to talk about its reproducibility in the setting of diabetic retinopathy. Then if it is reproducible in an ischemic retinal vascular disease, does it correlate with the degree of ischemia? Could the flicker parameters correlate with a fluorescein angiographic produced ischemic index? And if there is a correlation, could you then use this test to evaluate retinal function at baseline, and then following longitudinal treatment with anti-VEGF therapy? So with respect to answering the second question, the second bullet point of reference data, is it reproducible in a normal, healthy population? This paper came out 2 years ago. Jay Katz's group at Wills Eye Hospital did this study looking at the repeatability of the pattern ERG as well as the flicker ERG in a normal population. And I'll direct your attention to the bottom of this table, and we'll look just at the flicker ERG results. And you can see there were 47 eyes in 24 patients in this protocol that had the fixed luminance flicker ERG performed 3 times at different times during one day. So all 24 of these patients stayed around the Wills Eye Clinic for a day and came in at 3 separate occasions during the day and had the flicker ERG performed, and the magnitude and phase values were evaluated. And as you can see, that the interclass correlation coefficient value for the repeatability of the phase or the timing of the response to the flickering light was excellent at 0.994 with an excellent p-value. You know, this, remember, the interclass correlation coefficient is a statistical measure of consistency and reliability. And this study demonstrated that at least in an intra-sessional setting, in other words, you know, testing done in one day, that the results were repeatable. And in particular, the fixed luminance phase value was the one that was most consistent and reliable. Having said that, just as an aside, these are flicker tests done on me, one in 2016 on the left and one in 2017, a year later, on the right. And the test on the left was done at 8:43 in the morning prior to a clinic day, and the one on the right was done at 5:23 in the afternoon after seeing roughly 80 patients that day. And you can see that my test results for the fixed luminance flicker were quite repeatable. What is interesting is that although the phase values are virtually identical, the magnitude was less at the end of the day a year later, as opposed to the magnitude done in the morning of both my right and left eye. And I wondered to myself, you know, what might have produced this? And I wonder, you know, was I, you know, bleached to a certain degree after a full day of clinical evaluations? And I also did the multi-luminance flicker test on me as well, again, a year apart. And you can see that the test results on a normal person a year apart, because I say normal in the sense that I don't have any retinal vascular or any, you know, retinal disorder that I know of, that they're quite reproducible. So the third bullet point was to assess, well, now that we have determined that the flicker testing is reproducible in a normal population in multiple sessions on the same day, you know, and I just showed you that they were reproducible in me a year apart, are the test results reproducible in individuals with certain diseases? And my group and I published a report 18 months ago looking at the reproducibility of these two flicker tests in patients with diabetic retinopathy. Before speaking about the paper, I just wanted to mention why flicker. You know, traditionally, what has been well reported over the years is that the oscillatory potentials, which are the most sensitive indicator of early diabetic retinal disease. In other words, the oscillatory potentials, which are found on the ascending limb of a bright flash B wave, that the oscillatory potentials are lost. And that is well reported in not just diabetic retinopathy, but retinal vein occlusion, central retinal vein occlusion in particular. Well, it's not practical to do the oscillatory potential analysis because you need, you know, digital filtration techniques done in a lab in order to see them. So the next best candidate in terms of which particular electroretinographic test to use to track retinal ischemic disease is the flicker test. As you can see, the flicker test is demonstrated down here on the lower left. I also briefly wanted to mention this table, which was published in Survey of Ophthalmology in 1999, and it summarized all the electroretinographic studies that had been done in the setting of diabetic retinopathy, all done in a laboratory. And you can see the two black circles on the left-hand side of the table pointing out Simonson's 1980 paper and Bresnik's 1987 paper. And the reason I direct your attention to those is both of these papers were longitudinal studies. Simonson looked at primarily eyes, patients with no diabetic retinopathy or mild NPDR. Obviously, they're all diabetics, but you know, individuals with very mild to no NPDR versus Bresnik, who looked primarily at individuals with severe NPDR and individuals with proliferative diabetic retinopathy. And in both of these publications, it was demonstrated that oscillatory potentials as well as pattern ERG changes were quite consistent with progressive disease, and that you could use, this form of functional testing to gauge in an objective manner what was happening in an ischemic disease state such as diabetic retinopathy. So my paper investigates the intersession reproducibility of the flicker ERG in eyes with mild to moderate NPDR in the office. That was the primary endpoint to evaluate reproducibility. The secondary objectives were to see whether there might be any potential correlation between the degree of retinopathy as determined by ultra wide field fluorescein angiography and the flicker ERG. So patients with NPDR without a previous history of other disorders such as glaucoma, significant laser photocoagulation, any PRP or mild focal macular laser done recently prior to testing, any anti-VEGF therapy in the previous 4 months, or any ocular surgery were excluded. So we're really looking for individuals with relatively virginal pathology that had not been treated to evaluate whether the flicker ERG, both multiluminance, fixed lumens values, could be reproducible intersessionally, meaning over a period of time. So eyes excluded, obviously, any other form of retinal disease such as AMD, RVO, anyone with an optic neuropathy, and then finally anyone incapable of giving reliable test results such as those with tremor, blepharospasm, or dry eye, which would lead to excessive blinking. I designed this study in particular to look at 4 sets of testing sessions over a 4 to 8 week period. I made sure that each of these sessions was performed in the same office. I have the diopsis platform in my Maryland office as well as my Pennsylvania office. And so the background conditions remain the same during the testing. The tests were done with the same luminance level in the same room. They were done at a different time during the day because we could not keep that consistent, but they were all done within a 4 to 8 week period. And each session consisted of, both the multi-luminance fixed luminance test flicker tests, and ultra wide field fluorescein angiography was used to grade the level of retinopathy. So we evaluated 20 patients, that was 40 eyes, all with a history of mild to moderate NPDR. And when I say that, that wasn't me saying that they had mild to moderate NPDR based upon a clinical evaluation. That was determined by the Wisconsin Reading Center, which I used to evaluate the 40 angiograms in an objective blinded manner. And of the possible 320 ERG tests, because remember, each testing session consisted of 4 tests, the multi-luminance and the fixed lumens for each eye, and there's 4 tests done, or rather 4 testing dates for each patient. So it's a total possible number of 320. Excuse me, 304 were actually performed. 7 of the patients had their testing done within 4 weeks, 9 within 5, 3 within 6, and 1 patient, it took 8 weeks to get all 4 of their testing sessions undertaken. With respect to the patient demographics of this protocol, they were all Caucasian, age range 39 to 75. 3 were type 1 diabetics, 17 type 2. The retinopathy type, as it turns out, defined by Wisconsin's Reading Center, 33 of the 40 eyes had mild NPDR, 7 of the eyes had moderate NPDR, and the average duration of disease was 22 years. The in-office protocols are safe, they're easily repeatable, they're quick to perform. And I would add to this slide that although I write that the testing time is 10 minutes, over time your technicians get quite good at it. And in our office now, that testing time is closer to 5 to 7 minutes. With respect to the reproducibility results, the interclass correlation coefficient, which once again measures consistency and reliability, when you looked at the ICC of each of the potential test parameters, the multi-luminance mag and phase, the fixed luminance mag and phase, and finally the fixed luminance variance ratios for both mag and phase, that the one with the best ICC value turned out to be the fixed luminance phase value, similar to what Jay Katz found in a normal intra-sessional study. You can see also that the confidence interval, is quite good at 0.915 to 0.971. Another measure of reproducibility is the coefficient of variance, which is a statistical measure of variability. And once again, the fixed luminous phase value was the best one. In other words, a value of 0.036 tells us that if you were to do this test 100 times on the same patient, on the same eye, that 96 to 97 times those responses would be reproducible. And it is interesting to note once again that it was the fixed luminance phase values that were the ones that had the greatest degree of limited variability. With respect to the fluorescein angiography, before I get into what the correlation was, I want to point out that of the 40 eyes that had ultra wide field angiograms sent to Wisconsin, they have a grading scale there, and they give it a grade of each angiogram, each eye, a grade of either high confidence, adequate confidence, low confidence, or no confidence. And I have to tip my hat to Krista McChancy, my fluorescein angiographer at the time, because 36 of the 40 angiograms were given the highest confidence rating by Wisconsin's graded readers. So I feel it's safe to say that the fluorescein angiographic data that I'm presenting is reliable, and that you can see that the mean ischemic index was 0.0116, so not a whole lot of ischemia, which is what you would expect when you're submitting eyes with mostly mild and a few 7 with moderate NPDR, and you can see the range listed below. And the million-dollar question was there a correlation between any of the flicker parameters and the degree of ischemia? And once again, interestingly enough, the fixed luminance phase value, which is the one that has been deemed most reproducible, was the one found to have the most significant negative correlation. That is to say that there was a greater degree of ischemia when the fixed luminance phase values were declining. So as the timing of the retina's response, as the cone and bipolar cell timings to the flashing light, it gets prolonged, the degree of ischemia increases. So the fixed luminance phase values negatively correlated with the log ischemic index, in this cohort of patients. And I have two, quick cases to show you from this study. This is a patient with mild NPDR in both eyes, and you can see the quality of the ultra wide field angiograms for each eye are excellent. And you can see how reproducible the fixed luminance testing was in this patient. These 4 tests were obtained over a 4-week period of time. And you can see when you look at the magnitude phase plots for both the right and left eyes for each of the 4 testing sessions, that the magnitude values are consistent. The phase values, which speak to where those lines are directed, which is in the right lower quadrant, are very reproducible. Here's a second subject in the study. This subject had a greater degree of retinopathy, a greater degree of ischemia, a log ischemic index that was greater, particularly in the left eye, more so in the right eye. And here are this subject's 4 test results, which were obtained over an 8-week period. You can see that the fixed luminance phase values are not quite as reproducible as they were in the first subject, but remember, these tests were obtained over an 8-week period. Also remember that these tests were done undilated, and I now recommend that when you're doing the multiluminance and fixed luminance tests in retinal vascular disease that you do them dilated, because we now know from testing done on a diabetic population in the Yucatan Peninsula that your magnitude and phase values become even more consistent, even more reproducible when the pupils are dilated. Because theoretically, not just dilation can impact magnitude and phase, but so could time of day, caffeine intake, your hemoglobin A1C. There are multiple parameters that can impact reproducibility. And so once again, it's impressive to see that even over an 8-week period of time, the phase value in particular was reproducible when looking at the fixed luminance flicker test. So the clinical applications for this in my clinic are very simple. I get fixed luminance, multiluminance flicker testing usually annually, sometimes more often than that. It helps me guide the clinician, myself and my partners in terms of when to follow up. If I see magnitude and phase values dropping, that makes me more concerned, and I may see the patient back sooner. I don't routinely get fluorescein angiograms after my initial evaluation. I usually let a significant amount of time go by, but if I see the functional test demonstrating a reduction in magnitude or phase, I might get an angiogram sooner. Furthermore, I'm always asking about glycemic control, hemoglobin A1C values, and I'm frequently having my clinical staff reach out to the primary medical provider, cluing them in that, hey, we're seeing some retinal function that seems to be declining. We may get an angiogram and not see a whole lot of difference. Is the A1C getting worse? And bring that to the attention of the primary medical provider. And then finally, the last bullet point regarding clinical application is it possible to use these tests, these biomarkers to initiate therapy, and once you do, to help modulate it or discontinue therapy, particularly, in the setting of diabetic retinopathy. There are limitations to this little study. There are only 20 patients. Almost all of them were type 2 diabetics, and there was a relatively small age range. But nonetheless, the fixed luminance phase values were highly reproducible across multiple sessions over a 4 to 8 week period. I believe that the flicker ERG can be used to follow diabetic retinal disease longitudinally, and a larger multi-center study is currently underway to confirm these findings. Before I mention this study, just simply wanted to show this one case of a 78-year-old chap with a 9-year history of type 2 diabetes who was recruited into the Sapphire study here in the United States, evaluating intravitreal aflibercept as well as suprachoroidal triamcinolone in the setting of central and branch retinal vein occlusion. And this patient was recruited into this protocol, and he was allowed to be in the protocol because even though he had diabetes, he did not have any discernible diabetic retinopathy in either eye, and he presented with an infranasal macular BRVO in his right eye in 20/70 acuity. And you can see the color photograph on the left demonstrating the intraretinal hemorrhage cotton wool spot in the inferior MP bundle and edema extending into the fovea. You can see late phase angiogram and demonstrating diffuse leakage of fluorescein in this area and into the fovea. And you can see OCT of the right eye on the left, of the left eye on the right, demonstrating thickening intraretinal cystic changes extending from the MP bundle into the fovea. And as was expected, this patient's center involving edema improved with aflibercept therapy, But what is really quite impressive is when you look at the magnitude phase plot of the right eye, which is the circle in the middle of the report on the left, that the lines slowly move from the right lower, or rather left lower quadrant down the center and some into the right lower quadrant. And when you look at the table of the right eye, the initial magnitude value is in the 5 range, and over a period of time, it improves to over 10, as well as the phase value, which you can see in red at 246 degrees, slowly improves to 252, to 264, and then finally to 274. So here's a situation where someone receiving anti-VEGF therapy for a macular branch retinal vein occlusion without any discernible diabetic retinopathy had their magnitude and phase values improve sequentially with anti-VEGF therapy using aflibercept. Now, it doesn't make sense logically. Why would someone with a simple macular RVO, remember the flicker test is a test of global cone function, global bipolar cell function. Why would the magnitude and phase values improve? Remember, the area of involvement for the BRVO is very, very small, maybe less than 5% of the total retina, maybe even less than that. So it suggests that this patient's type 2 diabetes, he had a 9-year history of it, was somehow impacting global retinal function, which was then improved both from a magnitude / amplitude of responses, from a phase / implicit time or timing of responses notion. And that it furthermore suggests that, you know, diabetic retinopathy obviously is not just a microvasculopathy, it's a primary ganglion cellopathy. It impacts the choriocapillaris. That's already been shown using ultra high speed swept source OCT, and that all of the various cell types that are subject to chronic hyperglycemia may be impacted in such a way that can be quantitated using flicker testing. So this brings me finally to the Indigo study, which is being sponsored by Diopsis. You know, it's a quantitative evaluation of retinal function in eyes with diabetic retinopathy treated with anti-VEGF therapy. The study is looking at eyes that have center-involving edema, that are receiving any of the major anti-VEGF players, bevacizumab, ranibizumab, and aflibercept. And the concept is to evaluate the ability of the flicker ERG to detect, you know, dysfunction, you know, initially, and then, you know, track that degree of dysfunction as eyes are receiving anti-VEGF therapy. There are 10 centers across the United States. My understanding is that the trial has been almost 50% recruited, if not more. There are 2 groups in the trial. Eyes are being tested with 3 flicker tests over roughly a 6-month period of time that don't have center involving edema.
John, we've lost your audio.
Can you hear me now, Matt?
Yes. Thank you.
Okay, thank you. So we're very anxious to see what the results of the Indigo study will tell us. There's lots of good data to be had here, but the concept behind it simply is to see whether global function is improved with anti-VEGF therapy. To conclude my presentation, I want to present 2 cases. Both of them are central retinal vein occlusion cases. The first one is a 77-year-old gentleman with a 4-week history of reduced vision in his left eye. This gentleman was recruited into the Sapphire protocol as well. He had a central retinal vein occlusion. He presented with 2160 acuity in the left eye with the CRVO. He did not have an afferent pupillary defect in the eye. You can see on color fundus photography that he's got a dilated and tortuous venous tree with intraretinal hemorrhages, an ocular phenotype typical for central retinal vein occlusion. He had a raised central retinal venous pressure of 3, which at presentation meant for me that his vein pulsated when the artery pulsated with digital palpation. The mid and late phase angiogram gives you the classic appearance of a CRVO with a ratty foveal avascular zone and ischemia within the macula and diffuse leakage in the central macular region, as well as from the optic disc. On the left, you can see his presenting OCT demonstrating center involving edema, both intraretinal as well as subretinal, with a central subfield thickness of 851 microns. On the right, you can see his baseline fixed luminance flicker report demonstrating a relatively normal magnitude of 5.31 in the left eye, but a reduced phase value of 234, which is color-coded in red. I show you here the 3 OCTs over a 24-week period. You can see baseline, week 12 and week 24. And this patient was, the arm that he was in, he was receiving both intravitreal aflibercept as well as suprachoroidal triamcinolone, and he did not get monthly aflibercept therapy between week 12 and week 24, and he had recurrent edema. What I want to point out is that if you look at his baseline week 12 and week 24 flicker reports, initially, when you go from day 0 to week 12, his phase value improved from 234 to 251, telling us that the function of the living cone and bipolar cells improved. But the magnitude dropped from 5.31 to 3.93, telling me in all likelihood that the number of responding cells was declining. Then from week 12 to week 24, there was a significant reduction in both magnitude and phase, whereby the phase value dropped over 40 degrees. As it turns out, this eye became ischemic. He developed ocular neovascularization, both on the iris and in the angle. And angiographically, he had a greater degree of capillary closure than when seen at day 0. So this case is an excellent example of how flicker can alert you to, in the setting of central retinal vein occlusion, that an eye may be becoming ischemic. And remember that, in the old CRVO studies done back in the 80s, about 10 to 20% of CRVOs after presentation can become ischemic, and knowing which ones are going down that path can help guide, with therapy. I'm wondering to myself, had this patient been receiving weekly, or rather monthly, anti-VEGF therapy with aflibercept between week 12 and week 24, might some of the progressive ischemia have been averted? The second case is the reverse. It's a CRVO, a 54-year-old gentleman with a 4 to 5 day history of reduced left eye visual acuity. His past medical and ocular histories were unremarkable, and he presented, with 20/50 vision in the left eye and the classic stigmata of a central retinal vein occlusion. He also had a mild cilio-retinal artery occlusion, which we often see in individuals with a high venous pressure in the setting of CRVO. Here's a fluorescein angiogram of his normal right eye, and here we see an early and late phase angiogram of the left eye. And you can see, once again, a dilated and tortuous venous tree with diffuse retinal venous staining. You can also see the wedge-shaped area of ischemia in the inferior MP bundle, denoting the location of the cilio-retinal artery occlusion. You see, though, that there isn't really any leakage of fluorescein in the fovea, and at the time of presentation, the fovea was dry. So you can see an OCT of the right eye on the left and of the left eye on the right, and at the time of presentation with 20/50 vision, he did not have center involving edema, and I chose to just observe him carefully. Since he was relatively young at 54, I performed a systemic evaluation. All of the indices were essentially normal. When he came back to see me 4 weeks later, he had massive swelling, both intraretinal, cystic intraretinal change, as well as subretinal change, with a gigantic central subfield thickness, and his acuity was down to 2150-1, down from 2050 in the left eye. This is the flicker test that I got on this date, 4 weeks after presentation, and you can look at the mag phase plot of the left eye, which is on the right, and you can see that he has a reduced phase value compared to his fellow right eye. The phase value is 273 versus 289. The magnitude value is very high, and it's been reported in central retinal vein occlusion that amplitudes and magnitudes can be supra threshold at the time of CRVO presentation. And I think that's what was happening here. 4 weeks after his initial aflibercept injection, you can see that the intraretinal edema is resolving. He still has some persistent subretinal fluid on the OCT, and an acuity improvement of 20/60. Then after 4 weeks after the second, you can see the OCT of the central subfield thickness has improved almost completely normal. Then 4 weeks following the third aflibercept, he's back to 20/40 in this eye. I'm showing you this case because while he was improving, his flicker responses improved as well. You can see in the upper left, at the time of 4 weeks after presentation, you can see that that phase value, which was 273 in the left eye, improves to over 300 and stays there moving forward. And this is a case where I use the fixed luminance flicker to help guide me to discontinue therapy, because his central retinal venous pressure dropped, by pushing on the globe, and I surmised that perhaps he'd reperfused. So after 3 injections of aflibercept, I held aflibercept 4 weeks after the third injection, got the fixed luminance flicker, saw that the magnitude and phase values were holding steady in the left eye, did not inject, brought him back a month later, did the same, values stable, did not inject. So it's a situation where I could see that global retinal function was holding steady, and this is a situation where CRVO reperfused, and the test results with the in-office platform helped me discontinue therapy, which I've not needed to reinstitute over the following year. And you can see, 8 weeks following the third aflibercept injection, that the magnitude and phase values in the left eye were stable. So in conclusion, it's my belief that this in-office platform, this technology, can help clinicians track ischemic retinal vascular disease states from baseline and moving forward. I'm also optimistic over time that we're going to see that anti-VEGF therapy can improve function. Indigo will tell us a lot about that. And this very much has become a mainstay in my management of both diabetic retinopathy as well as central retinal vein occlusion. So I thank you for your attention.
Dr. Wroblewski, thank you very much. We really appreciate it. There are several questions. And by the way, if everyone has questions, please type them in. If we don't get to them today due to time constraints, we'll make sure that the presenters do respond, and we'll provide them to all of the attendees. A couple of things before we move on. Dr. Wroblewski, there are a couple of questions, and I'm going to kind of paraphrase them. The first one is, what has your experience been using the flicker ERG on patients where you cannot visualize the retina, where the structural information is limited to you?
I've got some good data on that in my clinic down in Mérida on the Yucatan Peninsula. We frequently see patients with no view, be it either from a dense cataract or from a vitreous hemorrhage. And what we have found is that flicker magnitude and phase values correlate with what we see on the B scan. If the retina is detached, the values are severely declined, and the variance ratios are so low that the data, is really not reliable, telling you that there's very advanced disease. Furthermore, even when the retina is attached and we take these eyes to the operating room, either to remove their, dense cataract precluding visualization of the fundus, or remove their vitreous hemorrhage pupil membranes, what have you, and the retina is attached, that we have learned that, the better the baseline values, the better prognostic value, meaning if the values are better at baseline and you get in there and you clean them out, they have a better chance of recovering central visual acuity. So I find the flicker test to be, quite helpful when evaluating eyes with opaque media.
Great. The last question, I know you have another engagement you have to go to. Have you initiated therapy independent of structural changes using flicker ERG? And I think your case had mentioned providing an endpoint, but would you mind spending 10 or 20 seconds on that question?
At this point, I have not. I think that, when you look at the diabetic retinopathy severity scores, for say moderate to severe NPDR, that most clinicians, at least retinologists in America, are still withholding therapy, even though, we know the results of Panorama, as well as, the results with ranibizumab, and looking at diabetic retinopathy severity score improvement with anti-VEGF therapy. So an individual without any stigmata of diabetic retinopathy at all, no microaneurysms, no intraretinal hemorrhages, I'd be at this point hesitant to treat. Having said that, when I have someone with moderate to severe NPDR who is on the verge of worsening, and I can track that functionally, yes, I'm willing to initiate therapy at those levels of diabetic retinopathy severity because I know that function is going downhill.
Thank you, Dr. Wroblewski. We appreciate it. And again, anyone, please send questions and we'll make sure that they get answered to you for you. Bill, I hope you're still on. If you'd like to introduce our next speaker, that would be great.
Sure. So our topic is now going to switch to glaucoma. Thank you, Dr. Wroblewski, for your excellent presentation, by the way. Our next speaker is Dr. Michel Puech from Paris, France, who I've known for 20 years, and he's a French ophthalmologist who specializes in ophthalmic imaging. He has a research degree, owner of patent on high-frequency ultrasound. He's the manager of Explore Vision Centers, which are 2 centers in Paris fully dedicated to ophthalmic imaging. Very impressive centers. He has everything. When I approached him a few years ago, I think that electrophysiology was the only thing he didn't have, but now he's been using it for a number of years. He's the organizer of the International Congress Ophthalmic Imaging from Theory to Current Practice. He's author and co-author of more than 25 books and many articles on OCT, OCTA, ultrasound, UVM, and IOL calculation. He's a lecturer at the Faculty of Medicine of Paris on glaucoma, cataract surgery, and OCT. And he is the organizer of the next World Ophthalmic Ultrasound Congress, which will take place in Paris in 2022. So I'd like to introduce Dr. Puech to give his presentation on glaucoma. Thank you.
Thank you very much, Bill. It's a great pleasure for me to be with you and to be a speaker in this web conference. You know that Diopsis have built machines that is very, very useful in an everyday clinic practice. You have seen implication for retina, and I will present to you the implications in glaucoma. I'm working in Paris, and so you have my email address and the email address of our centers. As Bill has yet informed to you, we have opened 2 of imaging centers in Paris because we have stopped surgery and we have stopped conventional ophthalmology, and we are 8 ophthalmologists only focused on ophthalmic imaging. Making this, we are able to use every kind of machines, every kind of devices, in every kind of imaging for the eyes. And for glaucoma, we are using visual fields, OCT angiography, electrophysiology, UBM, pachymetry, and we perform YAG laser and SLT. As you have heard, I organize a congress each year focused on ophthalmic imaging, every kind of ophthalmic imaging. If you want to send an abstract, please, this conference will be a mixed conference, probably in-person conference for the European ophthalmologists and digital conference for the others. Now we will focus this presentation on glaucoma, and especially by using this NOVA diopsis system. This is a new electrophysiology. You have seen with the presentation for retina that we are completely out of the conventional electrophysiology references. We now are using different details which bring this machine in a current practice with very, very usefulness for every doctors. We have a compact and mobile unit. We can use various stimuli. You will see all the panel of the stimuli. We are now using a new acquisition system, and we have a new signal processing. We are going to a frequency domain instead of the conventional domain of electrophysiology. And now we have an easy to understand report. Stimuli can include a pattern EEG. This is the main stimuli used in glaucoma, but you have multifocal ERG, you have full field ERG and PV. Using these different stimuli, you can focus your electric record of the response of the retina on different layers of the retina. In case of glaucoma, we are using a pattern ERG because this pattern ERG can underline the response, the electrical response of ganglion cells. And so we have protocols completely used to and completely performed for this this goal of glaucoma. One key point of this machine is we can use a stimulus monitor with a very high frequency, with a 15 Hertz stimulation of the screen, and you can observe on a 24 degrees. Making this, you can observe the response, but the other key point of the device is this lower lid electrode. You can observe this electrode, just put it in a lower lid in order to record the response. And this is a very, very convenient way in order to screen the patients for glaucoma, because they can go to a center for visual field, for OCT, for many exploration, and we can add this exploration of electrophysiology without hurting the globe, without contact lens electrodes. Condition of the examination for pattern ERG could be in a near distance, 61 centimeters. We can use glasses after 40 years old. We practice this exploration in dark condition, but we don't need pupil dilation, and time of acquisition is very quick. This new acquisition system avoids use of contact lens electrode, avoid Cantus electrode, and avoid large electrode. You have other competitors, other manufacturers providing other lower lids electrode, but you can see on this photographs that we have a large electrode in comparison with the diopsis system. And so, as we are quite near the globe, we have an efficiency. We have a more efficient way to record the data for electrophysiology. So it's very, very easy to use and very reproducible. Now, signal treatment is another key point from the system for diopsies, because we are quite at the same time that we have changed OCTs time domain to spectral domain. You have all understood what is the advantage of going to the spectral domain, because we are in a frequency domain. For electrophysiology, diopsies have made the same change in the philosophy of electrophysiology. All the other classical system on electrophysiology was based on time domain. Now, with the diopsy system, we are moving to frequency domain, and so this is the reason why the acquisition is different, but the signal treatment is completely different. And so, even if you are very specialized in electrophysiology in conventional systems, you can have a new approach with this diopsy system. You know that this is the regular response of ERG with a biphasic waveform of a normal patient, but now we have to go to this kind of analysis of the signal. In fact, we are stimulating the eye with a very high frequency system, and we are just recording the response of the layers of the retina. If you have a healthy retina, if you have no problem with the retina, the very high frequency stimuli will lead to a very quick response of the retina, and you will have this kind of stimulation, and the response of the retina will be on phase, and you have the results on the left. If you are in case of a reduction of the GCC responses, you have a modification of the phase of the response, and so you will have a final response like this. So you can easily understand that when we have no problem with the ganglion cells response, you have a normal response on the upper part of the screen. And if you have a change of the phase of the response of the GCC, you have this kind of images on the diagram. By using this system, you have to understand that we have new criteria in order to qualify the response. We can focus on magnitude. Magnitude can give you the quality of the signal, the signal strength. With a high magnitude, you have a normal response, but we can use magnitude D. Magnitude D is an analysis of the variation of magnitude and phase. And we can also use the ratio of magnitude D on magnitude, and this ratio can give you an approach of the phase response reproducibility. When we have a poor value, we have a GCC dysfunction, and you have the shame at the bottom of the screen with the in phase response of a normal eye, and with a late responses on phase on a glaucoma patient. The other key point in current practice, especially for us in our centers, because in our centers, 100% of patients are referred by another ophthalmologist. As we are very qualified and very specialized in ophthalmic imaging, all the doctors in Paris and all around France have many machines in the clinics. But when they have not the adequate, the perfect tool in order to give the response of the pathology of the patient, they can refer the patients to us. And when we refer back the patient to the doctor, they have to understand what we have seen and how we can explain what is normal, what is not normal. And on the conventional electrophysiology system, we have just the report of the doctor. But now the doctors can see this kind of reports. You have on the left a normal report with a color code response. With the green response, it's normal on the right and the left eye. And on the right part of the screen, you have an abnormal response in case of glaucoma. And you have the right eye with just the MACD on MAC ratio in yellow, and you have the other eye with a red response on two criteria. And so this MACD on MAC ratio seems to be the first reduced parameter in case of glaucoma. And so this kind of report can give you a better way to communicate with other doctors and to understand better with all your team and with the patient what is the response of this glaucoma patient in
way.
of this.
I think we hear you now.
This yeah.
Yes, now you work.
It's okay.
Good, you're
Okay,
good.
sorry. Did you have heard the previous slide? Do you want me to go back to the previous slide?
If you could, doctor, that would be wonderful. We
Okay.
did not get your last slide.
Okay, this slide was okay.
Yeah, that's fine. Yes, that one. That's fine. Thank you.
This was okay. So I was just telling that with the diopsis system, we have three criteria. We have a magnitude, which gives you an indication on the signal strength. The high magnitude can give you a normal response, corresponding to the normal response. Magnitude D is the analysis of variation of the magnitude and phase, and the ratio MACD on magnitude give you the reproducibility of the phase response. When you have a poor value with this ratio, you have a GCC dysfunction. The other advantage of the diopsis system is to give us a very understanding report. As we are working with many ophthalmologists in Paris and in France, they can refer the patients to us in order to practice exploration of the eye when they don't have any devices, and especially electrophysiology. And so when we send back the report to the doctors, they have to understand, because many doctors are not so used with electrophysiology. And so this manner that can be produced by diopsies can give a clear response, a clear report for the doctors. You can see on the left the right eye and the left eye that are on a green response with all the main criteria. And on the right, you have a glaucoma patient with different values of magnitude D, and the ratio in red for the left eye. It seems that MACD on MAG ratio could be the first reduced parameter in case of glaucoma. And this is a very important factor to observe in case of glaucoma. This very easy to understand report can give you this kind of response: normal patient with dysfunction of glaucoma, and we have a trend analysis from evolution of the patients, because when we have glaucoma, you can see the patient many times. And so you have this way of following the response with electrophysiology. Many years ago, we have had few presentations showing that PERG can anticipate an equivalent loss of OCT signal. And so you have very recent presentation. At the ARVO, you have had many presentations on electrophysiology and OCT, or electrophysiology and ganglion cell dysfunction. And so we are now with many teams working on this domain. And so we are, as we are specialized on imaging, we have many patients refer for glaucoma, and we practice for patients in case of glaucoma. We practice visual fields, we practice OCT with RNFL and GCC, and now we have had OCT angiography. And you will see that with this kind of use of OCT angiography, focus on the optic nerve head, you can select a superficial segmentation in order to see these very thin vessels all around the disc. And we know that this vascularization is completely joined to the RNFL layer. And so with a very superficial segmentation, we can observe the RNFL, but inside of the RNFL, you have vessels. And so probably this kind of approach could be very interesting for glaucoma approach. We have shown a few years ago that when you have this very dense network of vessels, of superficial networks around the disc, you can have the normal RNFL and normal GCC. When we have seen this patient with reduction of vascularization in this quadrant and thinning of the RNFL in the same quadrant, we probably have one new approach for glaucoma. With this patient, you can see this dramatic reduction of vascularization on the temporal part of both eyes, and you can see the thinning of the RNFL on both eyes, and you can see the visual field. So we have no doubt now with the relationship between this vascularization around the disc and with glaucoma, thinning of the RNFL. Due to different approach, we have been working with OptoView, and we are still working with OptoView in order to get measurements of this flow density in different quadrants around the disc. But the limitation of this was many machines can give you this flow density around the disc, but with all the capillaries. We have asked to OptoView in order to just select the thin vessels only involved in RNFL to make a subtraction, a digital subtraction of big vessels. And now, when we use this kind of device, we are able to give you just the flow density, just focus on the small vessels. One case report with this thinning, with this reduction of vascularization, you can see this lack of optic nerve fiber on the unfast OCT and the thinning of the RNFL, and you can see the response with GCC on the visual field. So now we can present the results with different quadrants, but we have conducted a study in order to make a correlation between RNFL thinning and reduction of flow density on the radial papillary vessels. We have shown on this series that on all the series, you have a positive relationship between reduction of vascularization around the disc and RNFL. If we split all these series and just follow different quadrants, you can observe that we have a positive relationship in each nasal quadrants, and the same thing in each of the temporal quadrants. So now we have this kind of response, and we are sure that we have a relationship with a very strong relationship between flow density and RNFL and flow density and GCC. But we have now machines that can enlarge acquisition with OCT angiography on all the macular region. And we know that if we have to focus to GCC, we have to focus to flow density on the macular region, because you can observe on this part the reduction of the flow around the disc and the reduction and the thinning of the RNFL, and you can observe also thinning of the GCC and reduction of the flow density in the macular region, on the same macular region. So now we are in front of evolution of the imaging for glaucoma that can show that we have a relationship between angioflow, vascularization of the GCC and around the disc, and the RNFL, but also with GCC. And now we have few presentation on the ARVO showing that in glaucoma suspects we have a relationship between GCC and response with the electrophysiology with the diopsy system. So we are now at the point that OCT can give us a very high definition acquisition for better segmentation. We enlarge the OCT field, and we can correlate structure and function of this patient. The first correlation was with visual field, but electrophysiology have yet been published with a conventional electrophysiology system by a few authors, and Natalia Kurisheva has shown this relationship. But with diopsies, we have now a new approach with this very specific system, and I will show you this short study on the 47 patients for glaucoma, referred to a Center for Glaucoma Screening. You have this electrophysiology approach and the OCT and OCT angiography. For the parameters, we have compared OCT with RNFL and GCC. We have recorded the OCT angiography with the peripapillary superficial vascular density. We have observed visual field with the VFI, and we have observed in electrophysiology the ratio magnitude on MAG, and we have used the Pearson coefficient. On this series, I show you the relationship between this ratio, MACD on magnitude ratio, against RNFL, against GCC, against VFI, and against angioflow. And you have a positive response on all these criteria, but we have the strongest response, the highly response with correlation between ratio on electrophysiology and GCC, and this ratio on electrophysiology and angioflow. This is very incredible because these patients can have a very, very easy approach with this system from diopsies, with this very small electrode, with this approach with a digital analysis of the signal. And we have also few presentations showing that if we follow the patient with the diopsy system, we can record a better response on electrophysiology after treatment. You can see this presentation on the arrow. So we are in the field of the imaging. We are now in field of glaucoma, and we can focus all these devices in order to better follow the patients and probably select the response to the treatment. So integrating diopsies functional visual test in the everyday clinical practice is very useful when we are focused on glaucoma. You are now a little bit more easy with this pattern ERG from diopsies. This new technology is completely different from the conventional electrophysiology. So you have to pay attention. If you don't have this system, you have to pay attention to this diopsies machine. We know that we have a statistical correlation between ERG, MACD, and MAG ratio with GCC and RNFL, with angioflow around the disc, and with VFI on a visual field. But now, if you want to correlate structure and function for this patient, we have now 3 criteria for structure. We can have GCC, we can have RNFL, we can have OCT angio. But the relationship with the functional part of the patient is mainly based on visual field. But visual field is a subjective response. You all know this. With electrophysiology, we are now at the point that we can have an objective response with no hurt with the patient, with a very easy exploration for the patient. And so this is a fantastic era of electrophysiology, and we have to thank diopsies to produce this kind of machine and to produce this kind of study. You have seen that many teams are working with these machines, and as we have all OCT and OCT angiography, probably the follow-up of our patient will be better, because this machine can give you, again, a compact and mobile unit. You have a pattern ERG stimulus, focus on ganglion cells. The new acquisition system is completely crazy, completely new with this small lead electrode. Signal processing is completely new with the frequency domain. And the easy to understand report can lead electrophysiology to everyday practice in order to understand and to better understand what is happening to this patient. So probably with this conjunction of all these advantages of this machine, we have the perfect tool for glaucoma at this time. And so we have to thank diopsies to produce this kind of machine. I have to thank diopsies for this invitation. And probably you have to discuss many other things during this conference. If you want to send me an abstract, please make it. And thank you again for the invitations. Thank you to everyone.
Thank you, Dr.
Thank you,
Puech.
Doc.
Go ahead, Matt.
Great, Dr. Puech, if we do have questions, and as I mentioned, we will get to these and we will send out responses for folks. But some things that have come up. So what do you do with a glaucoma suspect that's been sent to you that has reasonably normal fields or fields that are somewhat confusing, and normal OCT, but an abnormal pattern ERG? What steps might you take for that patient?
In fact, glaucoma is diagnosis of glaucoma is based on many criteria, and so till this time, if all the criteria was normal, doctors was not treating the patient. But now, if we add the new level of electrophysiology, we can give to the doctor a warning. We can give this warning because you have a non-normal response on electrophysiology, even if all the criteria on the anatomical approach are normal. And as you see, visual field is not the very, very quick response. It's not a very early response. And so probably our way of thinking is electrophysiology could be the first response of dysfunction of the ganglion cells. And so probably in these patients, we are not taking the decision to treat, but we can give a warning to the doctors that refer the patient to us. Please send us back this patient very soon and not let this patient without follow-up.
Excellent. Doctor, how easy was it to integrate this technology? You know, many of us have heard, or many of the people in the audience are familiar with the more significant laboratory-based ERG systems. What was your experience in terms of integrating this into your practice? Did you find this to be an easier method, an easier way to, and was it easy to integrate it into your routine?
Yeah, in fact, as you know, I'm not a conventional ophthalmologist, and so patients are referred by other doctors. And so we have many technicians in our two clinics. And we were afraid at the beginning because for me, electrophysiology was just the only imaging devices that we have had not by at the beginning of our adventure. We have opened the first center 15 years ago, and so we have many patients referred. And so that was the limitation of decision to have a conventional electrophysiology system. When I've met your company and when you have shown the system, it seems to be clear that the approach for the patient will be very easy. But our question was, will it be very easy for the doctors? And will we be able to give this machine to our technicians in order to get acquisition? In our two clinics, acquisition are delegated to technicians, and the reports are made by the doctors. And so we have teach few technicians, and now for our current practice, it's not a problem. They can perform this electrophysiology very easily, and the patients are very confident with this way of making. We are practicing OCT and angiography with technicians or with nurses, and so electrophysiology is very easy to delegate to our technicians.
Excellent. Bill, do you have any further questions? I'd like to proceed with the program.
Nope, I'm all set.
Dr. Puech, thank you so very much. And again, we will be forwarding you questions. We greatly respect your time and hope all is well. And we hope to see you at an international conference one of these days. We're looking forward to it.
Without pandemic, we will see.
Wonderful.
Okay, thank you very much. Thank you very much. Thank you to all the attendees.
Let me figure out how I can do this here.
Okay.
Okay, I think I've got it. So folks, what I'd like to do now briefly is we're going to have a little talk just to update you on the current paper level of research and published papers that are coming out. And both related to the retinal applications that Dr. Wroblewski was speaking of, but also with regard to others that have come out with regard to glaucoma. So just to mention a couple real quickly from the retinopathy side of things. As you know, we have always promoted this as a more accessible device, not just limited to the research lab. And in fact, there was a paper that's been accepted for ARVO that was presented by Stanford University. And what they were able to demonstrate was essentially the equivalence of our results with one of the larger systems, one of the systems that have been around in the classical electrophysiology labs. And that has been accepted by ARVO, and we're very pleased. We always knew that, but what we needed to get people to understand is we're not changing the study of the eye, we're making it more accessible to people. There is another paper that is in process that speaks to basically using the flicker to see how well it correlates with various stages of diabetic retinopathy. And that is in process and should be published shortly, but it correlated very well with people at risk, diabetics at high risk, mild NPDR, moderate NPDR, PDR, etc. And we hope to be able to show you, get that to you in the domain quickly. There are two other papers, and these speak to exactly what Dr. Puech was addressing. Essentially, the first one talks about using this device as a prognostic indicator of who is at risk for conversion from just your suspects, elevated IOPs. And what this was done at Manhattan Eye and Ear Hospital, and they took a look at patients that were at glaucoma risks. They did not have any findings on OCT nor visual field, merely elevated pressures. And what they found, they studied these patients for somewhere between 18 and 24 months. And what they found, and I hope you can see my slides. Let me make this a little bit bigger. What they found at baseline, when they first started observing these patients who were suspects, but only because of pressure differences, is that the baseline response of the pattern ERG was significantly lower with those patients that ultimately converted to glaucoma as confirmed by the OCT. Meaning that this is an awfully sensitive device that can help you make determinations as to who is at greatest risk. And the reason we mention that is because this is detecting the disease prior to cell death occurring. Meaning that if you can pick those patients that are going to progress and intervene, you may in fact be able to prevent cell death and progression of the disease. Conversely, I'm sure that you see many patients that have moderately elevated IOPs, and the question is, will they convert or will they not? And it has been demonstrated that we can be a very helpful biomarker on those patients where you've got mildly elevated IOPs. But these patients, as you know from the OATS study, 90% of these patients with mildly elevated IOP will never progress. And we believe that we can help you make that determination. The second paper that was also presented at ARVO basically spoke to those patients that did not have any structural damage, but in fact, they had early ERG changes and their IOPs were elevated. And what they found, and this is what Dr. Puech alluded to earlier, is that if they had dysfunction in the ganglion cells before it was demonstrated on any structural test, when they lowered the pressures on these patients, they found that the pattern ERG got better because you were helping to treat distressed living cells as opposed to treating cells that had already died. So I thought I'd share with you that information. There is more coming. Bill, is there anything else you'd like me to cover today?
Did you want to discuss our artificial intelligence?
Sure. Give me 1 second and I can get that going. Can you see the slide about photopic negative response?
Yes.
Okay, I'm just going to go into this briefly. We have always talked about pattern ERG as being the most sensitive functional biomarker for early ganglion cell changes. And of course, that relates to glaucoma. We actually discuss the effect of the diminished ganglion cell response. Oftentimes that can be related to glaucoma, but our study is on ganglion cells. And the pattern ERG works really very, very well. We are actually looking at another way of doing this using the Ganzfeld technology. And essentially, rather than the patient looking at the screen, and again, in order for the patient to do that, they have to be properly refracted and it has to be in a darkened room. If we use the Ganzfeld, a full field stimulator, if you remember from Dr. Wroblewski's presentation, we stimulated rapidly and we were looking primarily for responses from the bipolar and photoreceptors. If we stimulate in a different fashion, if I can demonstrate this, we will actually be able to tease out information related to the ganglion cells. So if in fact, this may be useful in glaucoma and other maculopathies that do affect ganglion cell response. Now, I will tell you that this is a little bit different from pattern ERG for a number of reasons. Pattern ERG is looking at central 24 degrees. When you do a full field stimulus, you're actually looking at the entire global retina. So you will get a contribution from ganglion cells that are outside of 24 degrees, even though the vast majority of ganglion cells are within that central 24 degrees. So for those of you who never wanted to see an ERG ever again, well, I'm sorry, but I have to explain this to you. When we stimulate in a slower fashion, remember the test that we described for pattern ERG and our flicker, the stimulus was going very, very rapidly, and you really don't get a chance to see this response. But if we slow down the stimulus, you actually get this complex from the stimulation. And this B wave and the A wave, they typically come from the photoreceptor layer and bipolar cells. However, if you look at the negative going response after this larger response, this is called a photopic negative response. And this is assumed to be derived from ganglion cell. So we thought we'd take a look at this, and we're not the only ones. This has been studied for many years, and it is a difficult measurement because some people look at just the size of this response. Some people look at just the speed of the response, but it's tricky because this is a very small reading. So that has been a difficulty that many manufacturers and researchers have faced over the years. But again, if we're going to look at ganglion cells, it's this little area of the response right there. And as I said, there are advantages and challenges to both. We know PERG very well. It's very well documented. We don't quite know photopic negative response quite as well, but the studies seem to indicate that they may be equivalent. We are working towards proving that, but I would have to say now that most of the research that's out there deals with how well pattern ERG works. It is the photopic negative response is a slightly less demanding test because you don't have to refract the patient. It can be, and it's simply the patient's not looking at a screen, but rather looking at that miniature Ganzfeld. This is what a report looks like. And again, I'm not going to dive too deeply into it, but in the past, most everyone have looked at how big is this response and how fast is it? And we do have reference ranges. The things you're really looking at, as we said, are how big and how fast. Now, we decided to take this a little bit further. In this age of machine learning and artificial intelligence, what we did is we took a whole bunch of normal patients and we took a whole bunch of glaucoma patients. And we fed this into a computer that is able to develop artificial intelligence algorithms. And when we did that, we came up with something called the multivariate analysis index, which is essentially artificial intelligence. And what this does is, rather than just looking at how big or how fast is that photopic negative response, that negative area here, what we are doing is actually analyzing over 600 data points throughout this complex, and we're doing it in multiple dimensions. And so what that is doing, and understand that artificial intelligence is primarily a binary decision, yes or no. So we've worked on that, and we took our initial algorithm that was developed with several hundred patients, and then what you have to do is then take that algorithm and send it out to other sites, not the original sites that you did it, because those sites were involved in the initial algorithm. And what we found in doing that is, again, we have this report that talks about the index. Green is good, yellow is not so good, and red is worse. We found that there was a sensitivity in the mid to low 90s and a specificity somewhere in the mid to low 80s, percentage-wise. And we think those are pretty good. The reason why I'm telling you about this is because for artificial intelligence to work really well, you have to feed the computers. So while we have released this product in certain areas, we are still gathering more intelligence to further feed the brain of the computer. So that is available in certain areas. We only assume as we get more experience that it's going to get better. But I thought I'd bring this up and mention it to you because it does look promising. Here as we stand today, there is more research related to the pattern ERG. In fact, as Dr. Puech mentioned, there are papers that actually are showing the retinal ganglion cell count and the vasculature correlating with pattern ERG responses. So there is more data to support it. We're hopeful we get there with the photopic negative response. So Bill, I'm going to turn it back to you. And I want to thank you all for your attention. By the way, my name is Matt Emmer. I'm Vice President of Business Development and Clinical Affairs. Our email, if you email the address that you have, info@diopsis.com, with any questions, they all get to us, and I assure you they'll all be answered. So Bill, I'm going to turn it right back to you.
Great. Thanks, Matt. Thanks, everyone. Are there any other questions? Matt, do you have any other questions coming in? Matt? I don't know.
Bill, there are a few. I think they require written responses.
Okay,
So
no problem.
I think that's our best bet.
Fine. So I'd like to thank our speakers, Dr. Puech and Dr. Wroblewski and Matt. Thanks for everyone's attention today. I think we can wrap this up a little early. Any questions that have come in that have not been answered will be addressed. And please keep a lookout, because we're continuing to have these symposiums, and keep a lookout for the next one. And again, thank you, everybody. Have a great weekend, and I guess that's a wrap. Thank you.
I want to also wish everyone health and safety, and we hope to see you at some meetings moving forward.